Chapter 2. Inhalational anesthetic agents. Volatile and gaseous anesthetic agents are used widely for maintenance of anesthesia and, under some circumstances, for induction of anesthesia. In many situations, it is appropriate to use a mixture of 66% N2O in oxygen and a small concentration of a volatile agent to maintain anesthesia, although for reasons discussed below there are occasions when an anesthetist might wish actively to avoid the use of nitrous oxide. Properties of the ideal inhalational anesthetic agent. It should have a pleasant odor, be non-irritant to the respiratory tract and allow pleasant and rapid induction of anesthesia. It should possess a low blood gas solubility, which permits rapid induction of and rapid recovery from anesthesia. It should be chemically stable in storage and should not interact with the material of anesthetic circuits or with soda lime. It should be neither flammable nor explosive. It should be capable of producing unconsciousness with analgesia and preferably some degree of muscle relaxation. It should be sufficiently potent to allow the use of high inspired oxygen concentrations when necessary. It should not be metabolized in the body, be non-toxic and not provoke allergic reactions. It should produce minimal depression of the cardiovascular and respiratory systems and should not interact with other drugs used commonly during anesthesia, for example pressor agents or catecholamines. It should be completely inert and eliminated completely and rapidly in an unchanged form via the lungs. It should be easy to administer using standard vaporizers. It should not be epileptogenic or raise intracranial pressure. None of the inhalational anesthetic agents approaches the standards required of the ideal agent. Minimum alveolar concentration, MAC. MAC is the minimum alveolar concentration, in volumes %, of an anesthetic at 1 atmosphere absolute, AT, which prevents movement to a standard surgical stimulus in 50% of the population. Anesthesia is related to the partial pressure of an inhalational agent in the brain rather than its percentage concentration in alveoli, but the term MAC has gained widespread acceptance as an index of anesthetic potency because it can be measured. It may be applied to all inhalational anesthetics and it permits comparison of different agents. However, it represents only one point on a dose-response curve. 1 MAC of one agent is equivalent in anesthetic potency to 1 MAC of another, but it does not follow that the agents are equipotent at 2 MAC. Nevertheless, in general terms, 0.5 MAC of one agent in combination with 0.5 MAC of another approximates to 1 MAC in total. The MAC values for the anesthetic agents quoted in Table 2.1 were determined experimentally in humans, volunteers, breathing a mixture of the agent in oxygen. MAC values vary under the following circumstances. Agents in common clinical use. Factors which lead to a reduction in MAC: sedative drugs such as pre-medication agents, analgesics, nitrous oxide increasing age drugs which affect neurotransmitter release such as methyldopa, pancuronium and clonidine, higher atmospheric pressure, as anesthetic potency is related to partial pressure. For example, MAC for Cevophlorin is 2.0%, 2.03 kilopascals, at a pressure of 1 atm, but 1.0%, still 2.03 kilopascals, at 2 atm. Hypertension, hypothermia, myxoedema, pregnancy. Factors which increase MAC: decreasing age, pyrexia-induced sympathorrenal stimulation, for example hypercapnia, the presence of ephedrine, or amphetamine, thyrotoxicosis, chronic alcohol ingestion. Mechanisms of action: general anesthetics act by the potentiation of inhibitory neurotransmitter pathways in the CNS, in particular by potentiation of GABA and glycine receptors, and inhibition of excitatory pathways such as NMDA. Both GABA and glycine receptors are associated with chloride channels, and binding of the ligand allows entry of chloride into the neuron-causing membrane. Hyperpolarization. General anesthetics, volatile agents, propofol, etimidate and thiopental, bind to the subunit of the GABA chloride receptor complex. Central nicotinic acetylcholine receptors, potassium and sodium channels are also activated by clinically relevant concentrations of volatile anesthetic agents. This can reduce presynaptic action potentials and reduce neurotransmitter release, and may also contribute to their mechanism of action. Individual anesthetic agents. Physical properties of the inhalational anesthetic agents are summarized in Appendix B, 2. The structural formulae of the agents discussed in this chapter are shown in Figure 2.1. Agents in common clinical use. In Western countries, it is customary to use one of the four modern volatile anesthetic agents, Isoflurane, Desphrone, Cevophlorin or halothane, vaporized in a mixture of nitrous oxide in oxygen or air and oxygen. The use of halothane has declined because of medico-legal pressure relating to the very rare occurrence of hepatotoxicity. The use of Cevophlorin has increased rapidly, particularly in pediatric anesthesia because of its superior quality as an inhalational induction agent. Desphrone produces rapid recovery from anesthesia, but it is very irritant to the airway and is therefore not used as an inhalational induction agent. Inhalational anesthetic agents. The following account of these agents, with a comparison of their pharmacological properties, may tend to exaggerate the differences between them. However, an equally satisfactory anesthetic may be administered in the majority of patients with any of the four agents. Isoflurane. Isoflurane, 1-chloro-2,2,2-trifluoroethyl ether, is an isomer of influrin and was synthesized in 1965. Clinical studies were undertaken in 1970, but because of early laboratory reports of carcinogenesis, which were not confirmed subsequently, it was not approved by the Food and Drug Administration in the United States until 1980. Physical properties. Isoflurane is a colorless, volatile liquid with a slightly pungent odor. It is stable and does not react with metal or other substances. It does not require preservatives. Isoflurane is non-flammable in clinical concentrations. The MAC of isoflurane is 1.15% in oxygen and 0.56% in 70% nitrous oxide. Uptake and distribution. Isoflurane has a low blood gas solubility of 1.4 and thus alveolar concentrations equilibrate fairly rapidly with inspired concentrations. The alveolar, or arterial, partial pressure of isoflurane increases to 50% of the inspired partial pressure within 4 to 8 minutes, and to 60% by 15 minutes, Figure 2.2. However, the rate of induction is limited by the pungency of the vapor and in clinical practice may be no faster than that achieved with halothane. The incidence of coughing or breath holding on induction is significantly greater with isoflurane than with halothane. It is not an ideal agent to use for inhalational induction. The rate of recovery is slower than that associated with Desphrone or Cevophlorin, but more rapid than after administration of halothane, Figure 2.3. Metabolism. Approximately 0.17% of the absorbed dose is metabolized. Metabolism takes place predominantly in the form of oxidation to produce difluoromethanol and trifluoroacetic acid. The former breaks down to formic acid and fluoride. Because of the minimal metabolism, only very small concentrations of serum fluoride ions are found, even after prolonged administration. The minimal metabolism renders hepatic and renal toxicity most unlikely. Agents in common clinical use. Respiratory system. In common with other modern volatile agents, it causes dose-dependent depression of ventilation, Figure 2.4, there is a decrease in tidal volume but an increase in ventilatory rate in the absence of opioid drugs. Isoflurane causes some respiratory irritation. This makes inhalational induction with isoflurane difficult. Cardiovascular system. In vitro, isoflurane is a myocardial depressant, but in clinical use there is less depression of cardiac output than with halothane or Isoflurane, Figure 2.5. Systemic hypertension occurs predominantly as a result of a reduction in systemic vascular resistance, Figs 2.6, 2.7. Arrhythmias are uncommon and there is little sensitization of the myocardium to catecholamines, Figure 2.8. In addition to dilating systemic arterioles, isoflurane causes coronary vasodilatation. In the past there has been some controversy regarding the safety of isoflurane in patients with coronary artery disease because of the possibility that the coronary steal syndrome may be induced. Dilatation in normal coronary arteries offers a low resistance to flow and may reduce perfusion through stenosed neighboring vessels. It has been shown that isoflurane affects small arterioles, which makes coronary steal a theoretical possibility, but this does not appear to be of any clinical significance. Production of myocardial ischemia in clinical practice may be a result of many factors in addition to coronary vasodilatation, including tachycardia, hypertension. Inhalational anesthetic agents. Increase in left ventricular end diastolic pressure and reduced ventricular compliance. Attention should be directed to these factors before a diagnosis of isoflurane-induced coronary steal is considered. Uterus isoflurane has an effect on the pregnant uterus similar to that of halothane. Central nervous system. Low concentrations of isoflurane do not cause any change in cerebral blood flow, abnormal apnea. In this respect, the drug is superior to halothane, which causes cerebral vasodilatation. However, higher inspired concentrations of isoflurane cause vasodilatation and increase cerebral blood flow. It does not cause seizure activity on the EEG. Agents in common clinical use. Muscle relaxation. Isoflurane causes dose-dependent depression of neuromuscular transmission with potentiation of non-depolarizing neuromuscular blocking drugs. In summary, the advantages of isoflurane are rapid recovery, minimal biotransformation with little risk of hepatic or renal toxicity, very low risk of arrhythmias. Muscle relaxation. Its disadvantage is a pungent odor which makes inhalational induction relatively unpleasant, particularly in children. Desphrone. Between 1959 and 1966, Terrell and his associates at Ohio Medical Products synthesized more than 700 compounds to try to produce improved inhalational anesthetic agents. Anesthetic agents. Two of these products were the halogenated methyl ethyl ethers, isoflurane and Influrane, which became widely used. Some of the original 700 products were re-examined many years later. Many were discarded for a variety of reasons. One of these, the 653rd, was difficult to synthesize because of a potentially explosive step using elemental fluorine, and it had a vapor pressure close to 1 atmosphere. However, because it was predicted to have a low solubility in blood and hence would allow rapid recovery, it was re-examined with heightened interest. This product became known as Desphrone. Desphrone was first used in humans in 1988 and it became available for general clinical use in the UK in 1993. Its structure, CHF20CHFCF3, differs from that of isoflurane, CHF20CHClCF3, only in the substitution of fluorine for chlorine. Physical properties: it is a colorless agent, which is stored in amber-colored bottles without preservative. It is not broken down by soda, lime, light or metals. It is non-flammable. Desphrone has a boiling point of 23.5 degrees Celsius and a vapor pressure of 88.5 kilopascals, 664 millimeters of mercury, at 20 degrees Celsius, and therefore it cannot be used in a standard vaporizer. A special vaporizer, the Tech 6, has been developed which requires a source of electric power to heat and pressurize it. The MAC of Desphrone is approximately 6% in oxygen, 3% in 60% nitrous oxide. As with all volatile agents, its MAC is higher in children, 9 to 10% in the neonate in oxygen, 7% in 60% nitrous oxide. It has an ethereal and pungent odor. Uptake and distribution. Desphrone has a blood-gas partition coefficient of 0.42, almost the same as that of nitrous oxide. The rate of equilibration of alveolar with inspired concentrations of Desphrone is virtually identical to that for nitrous oxide, figure 2.2. Induction of anesthesia is therefore extremely rapid in theory but limited somewhat by its pungent nature. However, it is possible to alter the depth of anesthesia very rapidly, and the rate of recovery of anesthesia is faster than that following any other volatile anesthetic agent, figure 2.3. Metabolism. There is very little defluorination of Desphrone, and after prolonged anesthesia there is only a very small increase in serum and urine trifluoroacetic acid concentrations. Approximately 0.02% of inhaled Desphrone is metabolized in the body. Respiratory system. Desphrone causes respiratory depression to a degree similar to that of Isoflurane up to a MAC of 1.5. It increases PaCO2, figure 2.4, and decreases the ventilatory response to imposed increases in PaCO2. It is irritant. Agents in common clinical use. To the upper respiratory tract, particularly at concentrations greater than 6%. It is therefore not recommended for gaseous induction of anesthesia because it causes coughing, breath holding and laryngospasm. Cardiovascular effects. Desphrone appears to have two distinct actions on the cardiovascular system. Firstly, its main actions are those which are similar to Isoflurane: dose-related decreases in systemic vascular resistance, myocardial contractility and mean arterial pressure, figs 2.5 to 2.7. Heart rate is unchanged at lower steady-state concentrations, but increases with higher concentrations, figure 2.9. Addition of nitrous oxide maintains heart rate unchanged. Cardiac output tends to be maintained as with Isoflurane. The second cardiovascular action occurs when its inspired concentration is increased rapidly to greater than 1 MAC. In the absence of premedicant drugs, this increases sympathetic activity, leading to increased heart rate and arterial pressure. Experimental studies in animals have not detected a coronary steal phenomenon. Desphrone, in common with Isoflurane and Cevophlorin, does not sensitize the myocardium to catecholamines, figure 2.8. Central nervous system. The effects of Desphrone are similar to those of Isoflurane. It depresses the AG in a dose-related manner. It does not cause seizure activity at any level of anesthesia, with or without hypocapnia. Desphrone decreases cerebrovascular resistance and increases intracranial pressure in a dose-related manner. In dogs, it increases cerebral blood flow at deep levels of anesthesia if systemic arterial pressure is maintained. Musculoskeletal system. Desphrone causes muscle relaxation in a dose-related manner. Concentrations exceeding 1 MAC produce fade in response to tetanic stimulation of the ulnar nerve. It enhances the effect of muscle relaxants. Studies in susceptible swine indicate that Desphrone may trigger malignant hypothermia. Therefore, in summary, Desphrone offers some advantages over other agents. It has a low blood solubility, therefore it offers more precise control of maintenance of anesthesia and rapid recovery. It is minimally biodegradable and therefore non-toxic to the liver and kidney. It does not cause convulsive activity on EEG. However, it has some significant drawbacks. It cannot be used for inhalational induction because of its irritant effects on the airway. It causes tachycardia at higher concentrations. It requires a special vaporizer. Although the TEC6 vaporizer is reasonably easy to use, it is more. Change in heart rate, %. Inhalational anesthetic agents. complex than the more conventional vaporizers and the potential for failure may be higher. It is expensive. Cevophlorin, fluoromethyl 2,2,2-trifluoro-1-ethyl ether, was first synthesized in 1968 and its clinical use reported in 1971. The initial development was slow because of some apparent toxic effects, which were found later to be caused by flawed experimental design. After its first use in volunteers in 1981, further work was delayed again because of problems of biotransformation and stability with soda lime. The drug has been available for general clinical use since 1990. Physical properties: it is non-flammable and has a pleasant smell. The blood-gas partition coefficient of sevoflurane is 0.69, which is about half that of isoflurane, 1.43, and closer to those of Desphrone, 0.42, and nitrous oxide, 0.44. The MAC value of sevoflurane in adults is between 1.7 and 2% in oxygen and 0.66% in 60% nitrous oxide. The MAC, in common with other volatile agents, is higher in children, 2.6% in oxygen and 2.0% in nitrous oxide, and neonates, 3.3%, and it is reduced in the elderly, 1.48%. It is stable and is stored in amber-colored bottles. In the presence of water, it undergoes some hydrolysis, and this reaction also occurs with soda lime. Uptake and distribution: sevoflurane has a low blood-gas partition coefficient, and therefore the rate of equilibration between alveolar and inspired concentrations is faster than that for halothane or isoflurane but slower than that for Desphrone, figure 2.2. It is non-irritant to the upper respiratory tract, and therefore the rate of induction of anesthesia should be faster than that with any of the other agents. Because of its higher partition coefficients in vessel-rich tissues, muscle and fat than corresponding values for Desphrone, the rate of recovery is slower than that after Desphrone anesthesia, figure 2.3. Metabolism: approximately 5% of the absorbed dose is metabolized in the liver to two main metabolites. The major breakdown product is hexafluoroisopropanol, an organic fluoride molecule which is excreted in the urine as a glucuronide conjugate. Although this molecule is potentially hepatotoxic, conjugation of hexafluoroisopropanol occurs so rapidly that clinically significant liver damage seems theoretically impossible. The second breakdown product is inorganic fluoride ion. The mean peak fluoride ion concentration after 60 minutes of anesthesia at 1 mAq is 22 moles L1, which is significantly higher than that after an equivalent dose of isoflurane. The metabolism of sevoflurane is catalyzed by the 2E1 isoform cytochrome P450, which may be induced by phenobarbital, isoniazid and ethanol, and inhibited by disulfiram. Respiratory system: the drug is non-irritant to the upper respiratory tract. It produces dose-dependent ventilatory depression, reduces respiratory drive in response to hypoxemia, and increases carbon dioxide partial pressure to a similar degree to other volatile agents, figure 2.4. The ventilatory depression associated with sevoflurane may result from a combination of central depression of medullary respiratory neurons and depression of diaphragmatic function and contractility. It relaxes bronchial smooth muscle but not as effectively as halothane. Cardiovascular system: the properties of sevoflurane are similar to those of isoflurane, with slightly smaller effects on heart rate, figure 2.9, and less coronary vasodilatation. It decreases arterial pressure, figure 2.7, mainly by reducing peripheral vascular resistance, figure 2.6, but cardiac output is well maintained over the normal anesthetic maintenance doses, figure 2.5. There is mild myocardial depression resulting from its effect on calcium channels. Sevoflurane does not differ from isoflurane in its sensitization of the myocardium to exogenous catecholamines, figure 2.8. It is a less potent coronary arteriolar dilator and does not appear to cause coronary steal. Cevophlorin is associated with a lower heart rate and therefore helps to reduce myocardial oxygen consumption. Central nervous system CNS effects are similar to those of isoflurane and Desphrone. Intracranial pressure increases at high inspired concentrations of cevophlorin, but this effect is minimal over the 0.5 to 1.0 Mach range. It decreases cerebral vascular resistance and cerebral metabolic rate. It does not cause excitatory effects on the EEG. Renal system. The peak concentration of inorganic fluoride after cevophlorin is similar to that after enflurane anesthesia, and there is a positive correlation between duration of exposure and the peak concentration of fluoride ions. Serum fluoride concentrations greater than 50 moles L1 have been reported. However, renal toxicity following anesthesia with cevophlorin does not appear to be related to inorganic fluoride concentrations as opposed to that associated with methoxyflurane. The apparent lack of renal toxicity with cevophlorin may be related to its rapid elimination from the body. This reduces the total amount of drug available for in vivo metabolism. Renal blood flow is well preserved with cevophlorin. Musculoskeletal system. Cevophlorin potentiates non-depolarizing muscle relaxants to a similar extent to isoflurane. Cevophlorin may trigger malignant hypothermia in susceptible patients. Obstetric use. There are limited data on the use of cevophlorin in the obstetric population. Interaction with carbon dioxide absorbers. Cevophlorin is absorbed and degraded by both soda lime and barrel lime. When mixed with soda lime in artificial situations, 5 breakdown products are identified, which are termed compounds A, B, C, D and D. These products are thought to be toxic in rats, primarily causing renal, hepatic and cerebral damage. However, in clinical situations, it is mainly compound A and, to a lesser extent, compound B that are produced. The evidence suggests that the concentration of compound A produced is well below the level that is toxic to animals. The use of barrel lime is associated with production of higher concentrations of compound A, and this may be related to the higher temperature which is attained when barrel lime is used. The presence of moisture reduces compound A formation. The concentration of compound A is highest during low-flow anesthesia, less than 2 liters minutes -1, and is reduced by increasing fresh gas flow rate. The toxicity of cevophlorin in combination with carbon dioxide absorbers is probably more a theoretical than a clinical problem. In summary, cevophlorin is a neuroinhalational anesthetic agent which offers many advantages over other volatile agents. These are smooth, fast induction, rapid recovery, ease of use, requiring conventional vaporizers, particularly when compared with Desphrone. Its disadvantages are production of potentially toxic metabolites in the body, more a theoretical problem, instability with carbon dioxide absorbers, relative expense. Halothane 2-bromo-2-chloro-1,1,1-trifluoroetane, was synthesized in 1951 and introduced into clinical practice in the UK.